We have with us Bryce Pardo, who's a policy researcher at the Rand Corporation. His work focuses on drug policy with an interest in cannabis regulation, opioid control, and psychoactive substance markets. Before going to Rand, he served as a policy analyst at the Inter-American Drug Abuse Control Commission within the Organization of American States. He's consulted with multilateral institutions such as the Pan American Health Organization and the UN Office on Drugs and Crime. He holds a PhD in public policy from the University of Maryland and an MA and BA from George Washington University in DC. I've asked him to come talk about fentanyl. I originally put a title on his talk on the agenda and the title was Stopping the Spread of Fentanyl. And he said, no, that's not what we're able to do. We're going to try to mitigate the spread. And so he tempered my expectations down there. And so I'm glad to hear from him, and I'll turn it over to him. Bryce, welcome.
Thank you, Chris. I'm really excited to be here today with you all. And indeed, unfortunately, I think stopping the spread is going to be difficult, given that some of the data we'll be showing you today probably will lead you to the same conclusion. So just to kind of give you a little background, yes, my name is Bryce Pardo. I'm a policy researcher at the Rand Corporation. And I've been working on this type of issue now for about synthetic opioids now since about 2017. So just to kind of give you some background about what we're going to be getting into here today, as most of you are aware of this, hold on, let me minimize that. Okay. Most of you are aware of the overdose crisis in the United States, largely driven by opioids since the beginning of this century. Really what has happened in the last few years has been this unprecedented rise in the number of deaths involving synthetic opioids. And so most of you have heard of the story of this kind of triple wave phenomenon, which had started with prescription opioids back in the mid 1990s. We had started to oversupply these markets for treating pain very aggressively, all types of acute and chronic pain with prescription pain medications. Well, about 8 to 10 years into this century, in 2008, 2009, 10, around that period of time, we realized we had overdone it. We started to put into place well-intended policies to constrain access to prescription medications. These included prescription drug monitoring programs, new guidelines on prescriptions, abuse deterrent formulations, and whatnot. Well, some of the work that my colleagues at Rand have shown, these well-intended policies may have pushed some individuals who were suffering from an opioid use disorder to seek out illicit opioids in illicit markets. And this is where we started to see heroin coming back. And we've had multiple heroin crises over many years throughout this country, going back to as early as the turn of the last century and in early parts of the 1900s. But again, in 2010, the first time we started to see use indicators for heroin starting to tip upwards. That continued for a few years until synthetic opioids, predominantly fentanyl, started showing up in illicit markets in late 2013, this kind of third wave. And this has really continued unabated. And you can see here, this data go through 2019, which is the latest we have individual data for. I'll show you some provisional data on 2020, but basically everything is trending in this direction. And so this is kind of the crisis of this is one of the major public health crises of our day. Just to kind of put this into perspective, the HIV AIDS epidemic, which was killing about, it was killing a lot of people in the beginning to mid 1990s. We're on par with that. Actually, now we're over, given the latest 2020 data, in terms of the numbers of individuals that are dying every year. So it's now one of the largest health crises. I mean, it's more than motor vehicle accidents, more than firearm deaths. It's incredible. Just to kind of give you some background about this presentation, all the data I'll be presenting today are public, unclassified, no conflict of interest to report. And Rand has been working on this, as I said, since 2017. All of these publications are freely available on our website. All of these culminated in this kind of monograph that we put together called The Future of Fentanyl. This is, to our knowledge, the most comprehensive assessment or analysis of the past, present, and possible futures of fentanyl in illicit drug markets. We looked at both the history here in the United States, as well as other places where fentanyl and other synthetic opioids have appeared and taken over in illicit drug markets. So the outline of this presentation, I'm going to cover kind of 4 areas. What has been the evolution of illegal supply of synthetic opioids? Where and who are dying from these drugs? Why are these synthetic opioids just now a problem? And how can we respond to mitigate this outbreak? So what has been the supply trends? Well, just briefly, synthetic opioids 101. Synthetic opioids is a very large term, but largely it just encompasses chemicals that are not, or opioids that play on the receptors in the brain, opioid receptors in the brain, that are not derived from poppy. These are chemicals, by and large, manufactured in laboratories. They don't rely on, the traditional kind of poppy growing phenomenon that we're used to seeing with heroin, where the stuff comes from Afghanistan or Mexico. In this case, no, this stuff is synthesized in a lab. There are many different types of synthetic opioids, but fentanyl is the dominant one per the overdose death data and the drug seizure data. So when I refer to synthetic opioids, I'm largely referring to fentanyl here, illegally manufactured fentanyl, but that's not the only one that we're seeing in the data series. And it's not just one molecule, as I mentioned. Things like methadone, which is used to treat opioid use disorder, tramadol, which is a very weak opioid, and then other things like diverted prescription fentanyl, such as patches or lozenges that make their way into the illicit market. They were prescribed, but then somehow somebody took them and moved them into the illicit market through unauthorized means. Those are also kind of captured in this generic term of synthetic opioids, but largely what we're going to be focusing on today are fentanyl analogs, non-fentanyl synthetic opioids, and non-pharmaceutical fentanyl. And these latter three are kind of the traditional ones that are finding or showing up in illegal markets or illegally produced. And those are the kind of concern today. This is not like the prescription opioid problem that we had seen years ago, where people were diverting prescription medications into illicit drug markets. That's not the case. What's happening here, these largely are illegally manufactured synthetic opioids in powder form that are illegally imported largely from Asia or Mexico. There is some domestic manufacturing of counterfeit pills that is happening here in the United States, and I'll discuss that a little later. But this is very separate from what we kind of have largely been aware of or accustomed to thinking about diverted pills. So for suppliers, the fentanyl really is the future. Just given the different dynamics of this product, it just is such a better drug for a supplier. So just to kind of compare here between four different dimensions, heroin, heroin has been the dominant illicit opioid in the United States now for over 100 years up until now. These are products that were cultivated from poppy largely in the hills of Mexico. In recent years, most of our heroin has come from Mexico. So it's cultivated in the hills of Mexico. It takes months to mature. These crops then there's massive amounts of labor that needs to be put into scoring the bulbs and extracting the opium, and then taking the opium and then synthesizing that into morphine and then later heroin. Well, that's in contrast to synthetic opioids, which just require simple chemical inputs. You just need to know synthesis methods and to have access to those inputs. And you can synthesize a sizable amount of fentanyl in a matter of a few days, in contrast to the amount of months it takes for plants to mature and to develop and then get extracted. So in terms of production, it just makes more sense for synthetic opioids just to win out long term. In addition to that, the analogs circumvent controls. These are new chemicals in many cases that we just don't have the ability to detect. Some of the detection equipments at ports of entry just aren't trained on these new analogs because we've never seen them before. Same thing with canine units. Canine units often may not be able to detect. We have to train the canine units to detect some of these newer synthetic opioids. So this just it is a much more advantageous drug to move or to produce. Potency is probably one of the key factors here. Everything is kind of measured against morphine. So heroin is about 3 times more potent than morphine in how it sits to the how it sits on the binding receptors in the brain. Whereas with synthetic opioids like fentanyl in particular, it can cross the blood-brain barrier and it can sit on those receptor sites much more efficiently. And so best guess is about 50 to 100 times more potent than morphine. And so when you take that into consideration, that means you need about 1/50th the amount by volume to move to get the same effect in the market. So from a kind of a trafficker standpoint, it just is more advantageous to move a smaller package. And that's what we're seeing today. That in combination with the production makes synthetic opioids much more profitable. The wholesale price is very, very cheap. You can find an online vendor in China willing to send you a kilogram of fentanyl for anywhere between $3,000 to $5,000. Compare that to about $25,000 to $50,000 at port of entry here in the United States for a kilogram of maybe half to 75% pure heroin. Once you dose that out, once you you can move this on the market, you figure, we did this kind of back of the envelope calculation, Fentanyl at port of entry or at wholesale is about perhaps 1% the wholesale cost of heroin after accounting for potency. So this really changes the game here. And then in addition to that, as I mentioned, provision, how this stuff is smuggled, by and large, because you can move a small amount of fentanyl through the mail system, it really just becomes a much bigger problem. So to give you a perspective, 10 grams of fentanyl, 10 grams is about 2 tablespoons of powder, of salt powder or sugar. Well, you can move that very easily in a letter. 10 grams of nearly pure fentanyl, if dosed out properly, is anywhere between 5 to 10,000 doses if done right. So you can see here that a little bit can go a long way. So by and large, the future suggests that profit-seeking individuals, dealers, will largely move to fentanyl and other synthetic opioids, given that it is just way more advantageous and accessible than heroin. So as I mentioned, China's role is really dominant here. The Chinese pharmaceutical and chemical industries are massive. China is the world's largest exporter of active pharmaceutical ingredients, or API. So if you had a headache this morning and you took an Advil, the ibuprofen that went into that Advil tablet came from China. Even though that tablet was manufactured here in the United States, the active pharmaceutical ingredient was manufactured in China. And so there are just it's just a massive industry that's under-policed, under-regulated. And so there's a lot of individuals who are kind of standing out in the shadows or out in the open that are manufacturing fentanyl and other synthetic opioids. A lot of times, these are PhD chemists who know what they're doing. They know how to read the synthesis literature. They know how to develop new synthesis methods or combine them to generate new substances. And so they're producing a lot of this stuff. At least up and through 2019, they were sending it directly to the United States. That seems not to be the case now anymore, though the drug trafficking organizations in Mexico are increasingly sourcing precursor chemicals from China. So we are still seeing a lot of seizures of fentanyl precursors that are making their way from China into Mexico. The drug trafficking organizations there are synthesizing this stuff and then shipping it across the border. Canada's happening. There's a little bit coming from Canada as well, but not to the same extent as Mexico. India is also out there. India is one of the largest, also the third largest exporter by value of API. And so their industry is also woefully underregulated. And so India is likely to be standing in the kind of in the wings here about with regard to producing and offering precursor chemicals and other synthetic opioids that could make their ways into the illicit market.
Bryce, just one quick question on that last slide.
Sure.
The numbers, the 5 and the 1, what are those references to?
That's just a DEA's. I took this slide from DEA's. It's in a footnote. It's not relevant to the topic of conversation.
Got it.
So looking at the individual seizure data, sorry, not individual, the aggregate level seizure data that is reported to the National Forensic Laboratory Information System, which is a DEA database. These are basically aggregate counts that are generated by state and local law enforcement officers. So every time a law enforcement officer happens upon a drug seizure, that information goes to the drug lab. The drug lab then records this information, analyzes it, and records that information, sends it to the DEA. DEA then aggregates all these up. And we can kind of see what's happening over time. And you can look here at the trend here of cases. There's limitations in interpreting this data, given that we can't infer whether this is wholesale or retail. We can't infer the mixtures, given that these are all aggregates. But nonetheless, you can still see the trend is upwards, and it's quite shockingly upwards. The numbers of synthetic opioids or fentanyl involved seizures up until 2014 were under 900 a year, very, very few. That has changed dramatically. Now we're posting over 125,000 seizure events involving synthetic opiates or involving fentanyl or fentanyl analogs since in 2019. In addition to that, we're seeing not only just fentanyl, but again, these other chemicals that are showing up. Several thousand are just other synthetic opioids that we've never seen before in some cases. These are fentanyl analogs or non-fentanyl synthetic opioids that are showing up in markets. And so this kind of chemical variation, as well as the numbers that are showing up, suggestive of a problem. And if you kind of correlate this with overdose deaths, which I'll show you in a second, there's a strong correlation. Just the numbers of overdose deaths are rising very sharply in recent years, as are the numbers of seizures. If you look at where this stuff is coming in or who's being exposed to it in terms of the geography, it's largely concentrated in the same places where we're seeing overdose deaths, but it's still an Eastern phenomenon. So looking at the trends over time in the United States, kind of ground zero for synthetic opioid seizure events are places in Appalachia, typically Ohio, and then in places in New England, predominantly New Hampshire. And that still seems to be the case up through 2019, where Ohio and New Hampshire still are kind of ground zero for fentanyl seizure events. And again, overdose deaths, I'll show you that in a second, correlate very strongly here. If you zoom in and look at some of these markets, you can see that there is this kind of inverse trend where fentanyl is displacing heroin in some of these affected markets. So here we have Massachusetts, New Hampshire, Ohio, and West Virginia, and you can see this inverse trend where fentanyl-involved seizures are increasing year over year, where heroin-involved seizures are declining. Unfortunately, these are aggregate level, so I can't see the mixture of these two, at least in the aggregate state level data that they're reporting, the DEA is reporting. But you can see this inverse trend. I have looked at the individual seizure data that is out there that somebody FOIA'd and put out on a public server. It only goes through 2016, 2017, so you can't get a sense of what's happening since then. But even in those individual seizure level data, you can see that the mixtures are going up. So over time, the mixtures of heroin and fentanyl seizures are going up, as are fentanyl-only seizures. Heroin is trending down in some of these states. So this is important to note that markets are transitioning away from heroin and becoming fentanyl markets in themselves. Recent trends in supply. Well, since 2019, the analog problem has kind of declined, pretty much largely declined. It's now just fentanyl. We're no longer seeing all these other analogs showing up. And this was people have kind of pointed to, and it's probably likely that the generic controls that the United States and China put into place in 2018 and 2019, respectively, may have had an effect in reducing the numbers of analogs that were showing up. And basically what's happening here is that a chemist, when a drug is controlled, that drug is when it's scheduled, that individual can no longer produce that drug legally. And so what that chemist will do often is they'll add or remove part of the molecular chain to generate a new substance that falls outside of those legal controls. And that was what was happening up until about 2019. We were seeing scores of new fentanyl analogs showing up. And again, these are like chemical variants or cousins of fentanyl, and nobody knew what they were doing. Nobody knew how strong they were, how harmful they were, or if they were harmful or biologically active. We didn't know. Some of these things had shown up for the first time in human history. So a lot of that has changed since 2019, in perhaps due to the generic or class-wide scheduling of fentanyl. In addition to that, there's been a sharp decline in the mail-based seizures from China. We were seizing the majority of the fentanyl that was making its way in the United States, according to seizure data, was coming by mail from China up through 2018. In 2019, those seizure events from China pretty much dropped off to zero. That said, Mexican drug trafficking organizations have increasingly moved towards fentanyl. There's a lot more seizures coming from Mexico involving fentanyl. At the same time, we're seeing fewer or indicators suggesting that heroin production is decreasing in Mexico, suggesting that the market there, these DTOs know that fentanyl is the future, and they're likely to increasingly supply the market, moving away from heroin, given how advantageous fentanyl is to heroin. And then since 2019, we've seen this rise in novel non-fentanyl synthetic opioids, likely from China, both here and in Europe. And these are the largest class right now are the benzimidazoles or the nitazines. And here, this figure on the bottom kind of shows you the chemical structures of different opioids that we're seeing in illicit markets. So you can see here that fentanyl is number 5 there. Well, the lower half of that panel are these benzimidazole series. And this is where you can kind of see by adding and removing just parts of that molecular chain, you can get a new substance that falls outside of existing controls. And so producers are continuing to generate faster than we can control these things. And so that's kind of what we're seeing in markets now. We're seeing these substances showing up both in the seizure data and the overdose death data. So where and who are affected? So as I showed you with regards to the exposure of the synthetic opioid seizure data, we're seeing the same trend in overdose death data. This is largely an Eastern phenomenon, east of the Mississippi River. And there's explanations for this. One explanation that probably holds the most ground is that the heroin market in the United States was largely bifurcated between powder heroin, which was more prevalent out east, and black and brown tar heroin, which was more prevalent out west. And so it's a little harder to mix in that powdered fentanyl with the tar, that gummier tar latex. So that may be one reason why we didn't see a lot of fentanyl showing up in markets out west, but we're starting to see that. We can see here that Arizona is kind of lighting up on this map in the 2019 panel. But again, there are major heroin markets in places like Seattle, Washington, Portland, Oregon, San Francisco, California, and we are seeing increased reports of both seizures and overdose deaths involving fentanyl in those markets. And it just could be a matter of time before fentanyl takes over, becomes entrenched in those markets like we have seen in places like Ohio or New England, where it's pretty much all fentanyl now. Looking at the United States, at the overall total death in the United States here, that first plot, that line plot that I showed you, showing the trends in different types of drug overdose deaths over time, this kind of zooms in and looks at the individual. This gives you a sense that, because that prior graph, those deaths are not mutually exclusive. An individual that reports both heroin and fentanyl in their system will get counted in both those lines. Well, what we would like to see is kind of the mixtures are involved in both. Again, this is kind of a polydrug substance problem, right? In some cases, heroin is getting contaminated with fentanyl, and we can see that here in this plot using the individual death data series. You can see the share of individuals that dying from heroin that also report synthetic opioids. And in 2019, more than half of heroin-involved overdoses also mentioned synthetic opioids, similar to cocaine. 60% in 2019 of cocaine overdose deaths included mention to synthetic opioids. So it's not quite clear what's happening with cocaine. We don't know if it's individuals that are out there buying cocaine and buying what they think is heroin to mix to a speedball, and then come to find out that heroin they purchased doesn't actually contain heroin, contains fentanyl. We don't know if it's that, or we don't know if it's dealers that are mixing a little bit of fentanyl into the cocaine supply to give that product a little kick. We don't know. But this is something suggestive of a kind of a polysubstance problem that is not specifically related just to cocaine. Our cocaine overdose death numbers are rising, but this is more of a suggested this is a synthetic opioid problem rather than a cocaine problem as of now. Psychostimulants also, about 25% of 25 to 30% of psychostimulant overdose deaths, methamphetamine, do include synthetic opioids. And so everything is kind of trending in this direction that synthetic opioids are just making their way into these different drug markets and largely contributing to overdose deaths. So this is something to kind of keep an eye on as this drug diffuses across states. Now, zooming in on individual states, you can see here that states are transitioning towards fentanyl, away from kind of traditional drugs of abuse, especially the traditional opioids. Here's Ohio. And you can see here that heroin-involved overdose deaths have declined, by about more than half since the peak in 2017-16. And now you can see here that the vast majority of heroin overdose deaths in Ohio contain synthetic opioids, similarly with cocaine and psychostimulants. New Hampshire is really a fentanyl market. You just don't find heroin there anymore. And to me, New Hampshire is analogous to Estonia, the Eastern European Baltic country that has long had a fentanyl problem going back to 2001. That market there has endured, it has matured, it continues to exist. Heroin never returned to that market. And I would suspect that in New Hampshire and other parts of New England, it's likely that heroin will never return to these drug markets, given the fact that both in terms of just economics, it makes more sense for dealers to move fentanyl than heroin, but also because of pharmacological effects. Individuals that become tolerant to a more potent opioid require a stronger opioid in order to avoid withdrawal symptoms. And so using heroin just won't cut it anymore for some of these folks. So this really changes the game in terms of the policy responses because of both economics and pharmacological effects. Here's West Virginia, again, also trending very quickly towards synthetic opioids across different drug overdose categories. So it's not suggested that we do have a polydrug problem, but this is a large part of our overdose problem is largely generated by synthetic opioids. And in some cases, users may not be aware that they're buying a product that is contaminated with synthetic opioids. And so it kind of puts a precedent on getting them to realize the elevated risks in using these substances in these markets, and also just reducing the overdose risk in some of these cases. In terms of demographics of who's dying, well, now largely the Black population is dying at higher rates of synthetic opioids than the white population. Traditionally, we had thought of the opioid crisis as being one of a rural kind of white problem. And that was largely true for prescription opioids, as you can see there in that first panel. But as of 2018 or so, the Black population has been dying at higher rates than the white population from synthetic opioids. And the story there seems to be kind of one of fentanyl diffusing, where we did see fentanyl showing up in markets like Ohio and New Hampshire, which are predominantly white states. It was showing up in kind of rural and suburban areas. That eventually made its way into major urban markets, heroin markets in the East Coast, so like Baltimore, Philadelphia, DC, New York. Those areas where fentanyl finally made their way in 2016, 2017, those markets were largely, the users in those markets were largely older Black males who have been using heroin on and off for decades. And then once fentanyl arrived, they went and bought their baggie of heroin from the dealer that they knew. And that market had transitioned to fentanyl. They used what they thought was heroin and they overdosed and died. That seems to be what's happening today now. Things have gotten worse since COVID. I'm sorry to be the bearer of bad news, but we anticipated that things were going to get tougher for individual drug users, given that social distancing requirements and kind of isolation would trend in a kind of negative way. So this plot here is from the CDC Provisional Overdose Death Series, and this shows you up until July of 2020 on the far right. That's the kind of the last data point is July of 2020. They show you the 12-month ending provisional overdose death numbers, and those horizontal the vertical lines there, the 25, 50, and 75%. Those show you the share of opioid-involved overdose deaths that involve synthetic opioids. So at the beginning of 2017, about half of all opioid-involved deaths included synthetic opioids. When COVID hit there in the beginning of March, February, about 75% of opioid-involved overdose deaths included synthetic opioids. That number is now above 80%. And so it's continuing to trend towards synthetic opioids. In terms of our overdose crisis regarding opioids, it's largely one it's driven by synthetic opioids. We've seen declines in prescriptions and declines in heroin. So just kind of keep that in mind. So why is this a problem now? Again, fentanyl is not a new drug. It was invented in the late 1950s, and it was approved for medical use both here and in Europe in the 1970s. And it's an essential medication. Any invasive surgery, you're going to need fentanyl to knock somebody out for a general anesthetic. It is a great general anesthetic. It's easier to revive someone. It's less cardiotoxic. It's a superior anesthetic. It's also a great tool for pain control, especially severe end-of-life cancer pain. It's used for that as well. And so this is an essential medication. It's been around for decades. So why isn't it that we didn't see this earlier? And so we kind of, scratching our heads, looking at the literature and looking at the data, going back as far as we could, we did note that, yeah, there were earlier outbreaks, but this outbreak is different. The one that started in late 2013 is different. It has not ended, and it doesn't seem to be slowing down at all. So why now? We identified 4 earlier outbreaks, going back to as early as 1979, where fentanyl analogs had made their way into illicit markets. The most recent prior outbreak was from 2005 to 2017. There was a blip of fentanyl showing up in some markets in the Midwest. However, today's fentanyl outbreak is very different for many reasons. We go through the 7 different factors that we could find in the Future of Fentanyl book. But to kind of give you a summary of them, one is that the synthesis methods have just really advanced. Initially, fentanyl, in order to make fentanyl, it required very precise procedures that necessitated controlling this stuff in high temperature, high pressure environments. And it was very dangerous to manufacture. Well, that is no longer the case. The synthesis technologies and methods have really improved to the point where now you can manufacture fentanyl in a single vessel at room temperature. The internet is also really has just expanded the reach with which fentanyl can make its way into these markets, as has cheap mail order delivery. I mean, now that I can buy a product from Amazon that is manufactured in China and have it delivered to my house in 5 minutes, the same phenomenon is happening pretty much with fentanyl and online vendors. And then as well as that, you've had this huge expansion of under-regulated pharmaceutical industries in China and India, just massive industries that have grown in the last two to 3 decades due to privatization and market forces in parts of Asia. And the regulatory industry there, the regulatory oversight there has just not kept up to pace. And it's just allowed individuals to kind of manufacture this stuff out in the open. So all these things combined has really just made this problem one that is beyond our control. So we identified 4 different outbreaks. These details are in the book. I welcome you to check it out. But basically, earlier outbreaks were largely smaller and shorter, and they largely contained only a few different substances. So kind of just walking you through the logic here of prior outbreaks versus the current one. Prior outbreaks were generally localized. They would show up in a market, one place, maybe a few different cities. That's not the case today, even though we have some regional variation, that east-west divide. It's happening everywhere and it's spreading. The duration was much shorter in prior outbreaks, with the exception of one. They lasted less than 3 years. Today we're going on 7 years with no end in sight. The chemicals used in the prior outbreaks, largely fentanyl, the smattering of a few analogs here and there. Again, analog generation wasn't that big of a problem then, given that the advancements in chemistry just have outpaced our ability to control this stuff. And so now you have scores of fentanyl analogs, as well as new non-fentanyl synthetic opioids that are showing up, like the benzodiazepols. Some cases, these things are extremely potent, much more potent than fentanyl itself. And so this just causes so much confusion in these markets because nobody really knows what they're dealing with anymore. The source in prior outbreaks, generally domestic labs with one exception. So it was somebody who knew a little bit about chemistry, was manufacturing this stuff. That's not the case today. It's almost all imported from China and Mexico. Distribution networks are also different. Prior outbreaks, largely traditional drug trafficking organizations or other kind of criminal groups that were manufacturing and then distributing this stuff in local markets. Today, you have major drug trafficking organizations like the Sinaloa cartel, the CMJG cartel, as well as the internet. Anybody, anywhere can go online and in some cases buy this stuff direct to their door from China. And this just creates a lot of confusion and a lot of just kind of atomizes this problem in many different ways that we're not used to. And then lastly, in prior outbreaks, fentanyl was largely sold in heroin as heroin or better quality heroin. The term China white was coined back then due to fentanyl showing up in heroin markets. Today, it's showing up in heroin as well as in counterfeit prescription pills. And that's a serious concern because if you're a drug user, I mean, typically heroin users don't know what kind of quality heroin they're going to get. And so it could be a good night or a bad night. But if you're buying a prescription pill from an illicit market, generally people think that pill is of legitimate pharmaceutical origin and there's some sort of dosage consistency in that product. Well, that's no longer the case so much anymore, given that individuals can import fentanyl here, press it into a counterfeit tablet that's made to look just like an OxyContin 30 milligram tablet, when in fact that tablet contains no OxyContin, maybe contains 2 to 3 milligrams of fentanyl. They overdose and they die. In addition to that, we are starting to see it a little bit in cocaine supply and a little bit in the methamphetamine supply, though it's still unclear to what extent that is happening. So in summary of all of this, synthetic opioids really complicate all levels of drug policy. In terms of supply, for example, these new chemicals oftentimes will escape legal controls and detection efforts, as I mentioned. Canine units aren't trained for some of this stuff. The point and shoot technologies like the FTIR machines that are used at customs facilities, those things need to be trained on new libraries. And so some of these chemicals are showing up for the first time in human history. We don't know what we're seeing. So it's going to take time for people to kind of catch up to what's being produced. In addition to that, as I mentioned, potent drugs are easier to conceal, so it makes it harder for drug law enforcement to do their job. You know, before the kind of analogy was trying to interdict heroin at say a port of entry or an international mail facility. It was like trying to find a needle in a haystack. Well, now with fentanyl, it's trying to it's almost like trying to find a bacteria colony on that needle in that haystack. Just much more complicated. In terms of demand, synthetic opioids are really complicating our ability to kind of treat opioid use disorder, given the greater potency. Given that tolerance is people are increasingly becoming more tolerant to drugs that are used in the illicit market, traditional kind of treatment modalities may not be sufficient. Thinking about methadone, if we've treated heroin use disorder with methadone very well for decades, and now if an individual has become more tolerant to a stronger opioid, the available kind of dosages of methadone may not be enough for that individual. So we really need to start changing the way we dose out methadone or thinking about how we offer methadone. In addition to that, we may need to start thinking about other agonist therapies beyond just buprenorphine and methadone. Canada has been aggressively promoting other kind of harm reduction mechanisms as well as prescription heroin. And that's something that the research has shown very successfully that prescription heroin does show benefits. And so thinking about other agonist therapies like that or hydromorphone might be something to consider at this point. And in terms of harm reduction, this is really crux. The chemical variation in what's showing up in these markets just generates so much confusion and really augments the risk of overdose. Both the dealers and the users don't really know what they're handling if these chemical variants are coming in and out of markets very quickly. So last week, the powder that I was moving was purple. This week it's gray, and the week after that it might be blue. I don't know. I'm just moving whatever my dealer or my distributor was supplying me. And so this kind of chemical variation really augments risk to both to drug users, just given that the variation in what's there and what's being sourced, nobody really knows how to dose. Nobody really knows what the effects are. Counterfeiting, as I mentioned, serious concern with counterfeiting since people don't know what they're coming into contact with. And it's really quite concerning given that fentanyl has been showing up not only in pills made to look like fake oxys, but also in Xanax bars, which are not supposed to contain any opioids whatsoever, but benzodiazepines. So this is a serious concern given that counterfeiting just generates way more confusion in these markets that can elevate overdose risk. And then also new drugs may pose new harms. We just don't know. In some cases, some of the anecdotal evidence in the online forums of people that use opioids, they discuss some of these newer non-fentanyl synthetic opioids having different effects. In some cases, some people report very, very different kind of, in some cases, almost depression and anxiety-like effects that are not associated with kind of a typical opioid use. So it could be that maybe some of these drugs, there are different mechanisms of action we just don't know about that are happening in the brain. And so that could cause other harm or other kind of long-term problems that we have to deal with. In addition to that, the fact that we have a more potent opioid, or one that can bind to some of the receptor sites more strongly, may require more frequent doses of naloxone or more administrations of naloxone. There has been some data in the literature to suggest that EMS first responders show up at an overdose scene, and a Narcan kit used to do it maybe 5 years ago, and now they got to hit this guy with 3, 4, 5 doses of Narcan to bring them back. So that's something to consider as well. The last thing I didn't put on here, but one of is the kind of duration of effect. Fentanyl is a very fast acting and very potent opioid, but the duration of effect is much shorter than heroin. And so it's about half as long, it stays in the system about half as long as heroin. And so some users report in the ethnographic literature that they got to actually now hustle twice as much and use twice as much in order to kind of maintain stability. And so thinking about what that does to the harms for users, it just basically doubles their risk of overdose, because now they have to inject twice as much. It doubles their risk of bloodborne disease transmission because they have to inject twice as much. Prices have not fallen as best as we can tell, so that means they have to hustle twice as much in order to pay for the Medicaid, to pay for the drugs. So all of these things kind of have rippling effects downward that are much more harmful both to the users and the community that they live in. So how do we respond? Well, kind of broad policy considerations, thinking about how do we differentiate both law enforcement responses and other kind of public health interventions, given the variation in supply channels. So as I pointed out, we have an east-west phenomenon. We also have a traditional kind of supply mechanism through the drug trafficking organizations from Mexico that are moving away from heroin towards fentanyl. But we also have this new phenomenon of individuals obtaining the stuff online and then selling it downstream on the street or in their community. And so that kind of atomizes this problem. So how do we kind of differentiate responses for different supply channels in different areas where fentanyl is entrenched or where fentanyl hasn't shown up yet? And then thinking about improving monitoring of these markets, that's going to be crucial, given that really the chemical evolution in these markets is just far outpacing our ability to understand them. So we need to do things like enhanced drug overdose death analysis, seizure analysis, as well as wastewater testing. And then lastly, thinking about reducing barriers to treatment and more innovative treatment and harm reduction intervention. So really, like, the key take home here is that we need technological and policy innovation to really get around this, because what we're doing right now, it's not working. We can continue to spend more money in treatment. We can continue to spend more money in law enforcement, but we really need to think more creatively about this problem, given that it's presenting new harms and new problems for us to kind of get around. So we need to start thinking more innovatively. So there are kind of 3 buckets we could look at. One is, okay, how do we reduce exposure and risk? Some off-the-wall ideas, increasing transparency in markets, things like better analysis of what's happening in these markets and alerting individuals early on to the arrival of fentanyl or carfentanil in some of these markets may help. Fentanyl test strips might be one way of getting people to realize, okay, what is it that's in the market, especially if you're a cocaine user and you buy a white powder. You probably want to test that with a fentanyl test strip to make sure that your cocaine doesn't have any fentanyl in it. That could very well save your life. Thinking about other off-the-wall ideas like a neutralizing agent. You could spray this on a powder and it somehow clumps to the fentanyl and it no longer is active, or somehow you can't use that substance. Other things like supervising drug consumption. This is something that Canada has been doing and doubling down on very aggressively, opening up supervised consumption facilities or overdose prevention sites whereby individuals that purchase their drug off the street go to these facilities, they use their drugs there under some sort of supervision. If they overdose, a nurse or a doctor or somebody else that's trained can then step in and administer naloxone to reverse that overdose. Other things like medication-based prophylaxis. So thinking about vaccinations, there is, in theory, it does work where you could vaccinate someone for fentanyl exposure such that antibodies bind to the chemical before it passes the blood-brain barrier. So it's not pharmacologically or not psychoactive in the brain. I mean, in theory, it does work, but logistically, it has been a challenge. And then thinking about heroin-assisted therapy. And we did a very deep dive on heroin-assisted therapy a couple of years ago. The literature there is very positive. There's a lot of randomized controlled trials comparing supervised heroin-assisted therapy compared to methadone, and HAT definitely has better outcomes than methadone. I mean, again, the questions here are, how do we scale this up? How do we get this into some communities where we already have poor access to transportation or healthcare interventions? It's going to be difficult to kind of scale this out everywhere in the United States, but nonetheless, these are kind of some things that we should be starting to think about and talk about. Creative supply disruption. I mentioned earlier, we have this online sourcing phenomenon. So how do we deter online sales? Maybe creating fake websites that that just collect information, that just kind of poison the well, because it's very easy to go online to find a purported vendor who will sell you fentanyl. So how do we kind of create fake websites that maybe deter individuals from sourcing online? We need to do better network analysis to understand how this stuff is coming here, how it's being delivered to the mail system. That's something that DEA and other law enforcement may want to consider. Focused deterrence is something I'm not going to get too much into, but basically the theory there is encouraging dealers to act more responsibly when selling this stuff. So instead of buying and selling analogs, try to encourage them not to sell analogs, try to encourage them not to press this stuff into counterfeit pills. And you do that using kind of a targeted effort at really throwing the book at those that are, you act very urgently and aggressively, those that are acting most flagrantly and causing the most harm in some of those communities. And then again, targeting counterfeit pill operations, given that it just generates so much confusion. And then lastly, monitoring and surveillance are really going to be key, given that the evolution of these chemicals, it just far outpaces our ability to understand them. So we need to get better at measuring what's happening through better seizure data analysis, which often lag a few years. The NIFLS system doesn't offer us individual level data. We, researchers like myself would really like to see these data so that we can kind of understand how these markets are transitioning. Unfortunately, a lot of law enforcement seizure data is a protected information. They do not want to give it publicly, or in some cases through MOUs. And so it's very difficult to kind of understand how these markets are transitioning. Then thinking about other innovative data collection systems like the ADAM, the Arrestee Drug Abuse Monitoring System, whereby individuals that were coming into jails arrested for other crimes, you would ask them about their drug use, and then you would have them take a urine sample. It wouldn't affect their case or their criminal charges or anything, but it would give us an understanding of what drugs they were using in their system. And then you could actually confirm whether or not they were using a certain substance. And that would be really helpful to understand what's happening in these markets. And then lastly, wastewater testing. We need to get more aggressive at testing wastewater and understanding what's being used in these markets. I mean, imagine if we had wastewater testing 5 years ago, and to alert a city like St. Louis, where fentanyl wasn't there 5 years ago and it started to show up, alerting them through wastewater testing, saying, hey, we're seeing a huge spike in the metabolite loads for fentanyl and carfentanil, watch out. It could have maybe saved lives. Wastewater testing has been used in Europe now for almost 20 years with quite good success. They can see in real time when people are using drugs and what drugs they're using. And so it can kind of give us a better sense as to what's happening in real time in these markets. So maybe the last thing to consider here is that really, this is like a poisoning outbreak rather than a traditional drug epidemic. I mean, people at least initially, aren't seeking out fentanyl, though that does change once that market transitions over and people become tolerant. They become, fentanyl seeking. But initially, it's the dealers or the suppliers who see this as a much better substance to traffic in and to deal in, because it's just the profit margins are much larger. So how do we think about it? Maybe framing it as a poisoning outbreak might help us kind of get there in terms of moving towards this innovation. So again, improving transparency in markets, reducing the exposure and overdose risk by those that use drugs, and then innovatively disrupting new modes of supply are kind of the three key takeaways we can start doing to kind of help mitigate this problem. So with that, I thank you and I look forward to your questions.
Okay, so see some hands going up. I had some questions in the pipeline already. So Alva Amwine, and then Barbara, and then Madeline, then Kyle.
Hi there. I had a question about the fact that you mentioned that the hub for making fentanyl is Mexico and China. And I'm just so curious, is there a heroin problem in these places that justifies it? Like, why is it those two places? I understand that there's regulation, but are there other factors that determine why these have become such hot spots? Because it feels like China is always coming up in these discussion. Mexico, obviously, their drug cartels, they get a lot of press, and I'm just curious about that supply chain more. And so just wondering why, not only like if there's a heroin problem in China and Mexico to justify that kind of it being the hub, but then also, is it difficult to reproduce fentanyl in the United States? Like, why focus on the Chinese and the Mexicans? Like, is it because there's more regulation in the US that it has to be imported from these places? Like, I'm just unclear how that whole life stream goes.
Sure. So Mexico has long supplied our demand for illicit drugs, going back to over 100 years. They've just been doing that. With regard to heroin, poppy cultivation started showing up in Mexico. Well, during World War II, when we lost access to China due to the Pacific War. But that said, I mean, heroin has always been produced. Poppy has always been produced in Mexico, on and off, up and down through different swings. They have become the dominant heroin supplier for the United States since about 2005. But now they're moving into fentanyl, and a large part has to do with these are profit-seeking and very profit-hungry organizations that are competitive. And so once one trafficking organization goes into fentanyl production, others have to follow suit in order to stay competitive. And so that's what's happening there. In China, there is a heroin problem. It's not that big. They largely have a methamphetamine use problem. But again, it just has to do with not good regulations. And we've seen the consumer safety protections there lacking in all sorts of other things. I mean, they're a massive producer of all sorts of things. And in terms of consumer safety problems, we've seen lead in lead paint in children's toys, antifreeze in toothpaste, melamine in cat and dog food, all coming from China. And so this just has to do with the kind of poor regulatory structure and enforcement efforts that are there in that country that's just now bleeding into psychoactive drugs. And that's just kind of what's happening there.
Okay, next question to Barbara.
Yeah, I work for the NBC station in Providence, Rhode Island, obviously a hotbed here in New England. My question is, are more people seeing out fentanyl in particular, or are they getting it via trying to get another drug? And then my other question is, why aren't the fentanyl test strips actually picking up in popularity? I visited a safe injection site in Montreal a year and a half ago, and they readily goes out to everybody who goes to safe injection site. And then maybe you want to talk about safe injection sites and why we're not seeing them in the United States.
Sure thing. So fentanyl showing up in, so initially fentanyl is something that we think is a dealer-driven phenomenon. It's not that users are seeking out more potent opioids. They're looking for their standard dose. Initially they were looking for pills because that's what in some cases, they got hooked on pills. Pills, the benefit of using prescription pills is that the dosing consistency is there. If you're getting something that's regulated, you know that it's going to contain 30 or 80 milligrams of oxycodone. And oxycodone and heroin pretty much have the same effect. And so it would be better from a user's perspective to get something of known purity and dosing. Well, heroin is cheaper, and so heroin is accessible, and so that's what people traded down to. And then all of a sudden, dealers said, "Well, I can supply the market. I can sprinkle a little bit of fentanyl in, cut my heroin, sprinkle a little fentanyl in, and just sell this as good quality heroin." And that seemed to be what was happening initially, is that people were buying baggies of heroin of good shit. They thought they were buying good shit. It turns out it was actually fentanyl. And then over time, that ratio of fentanyl to heroin shrunk. And that baggie of heroin contained no heroin overall at the end. And so eventually that market transitions over because of tolerance. And so eventually people start seeking out fentanyl because they become tolerant. So that's what's happening there. With fentanyl test strips, there's not it's an interesting idea. And I think it could be useful for non-opioid users. But once a market transitions over to fentanyl, everything contains fentanyl. And those test strips, they just tell you they're binary answers, yes or no. It's like a pregnancy test. Well, it does me no good to know whether or not my heroin that I just bought has fentanyl or not, because everything has fentanyl. It would be beneficial if you're a non-opioid user and you want to use a test strip to avoid coming into contact with fentanyl. So the differentiation there might be key. And so that might be one of the reasons why, if you're a heroin user and the market's transitioned over, why bother testing your product? Because everything has it. Really what you want to know is the concentration. And there's no technology out there that's kind of street ready or street deployable. Canada in Insight, which is the kind of the Cadillac supervised consumption facility there in Vancouver, they actually have an FTIR machine where you can go, you give them a sample, and they will actually, in that sample, they can test what the concentration is of fentanyl, and then they'll tell you. So that's something, in addition to doing the fentanyl test strips, they can take a little bit back for you and then tell you whether or not that product, what the concentration is. And some individuals then can kind of get a sense of, okay, what is the dose here in this market? And then lastly, with supervised consumption facilities, yeah, Rand did a big report looking at that. Supervised consumption facilities have been around now in the world for over 30 years. They started out in Europe. Canada opened them up about 20 years ago. And now Canada has dozens of these across the country. They opened up in Vancouver, and they're really doubling down on these and other overdose prevention centers where they just are throwing up basically a tent, telling people to come use here, and someone will oversee your use and supervise your use. And then if you do overdose, we're gonna give you naloxone to make sure that you're not going to die. And so they've been very aggressive in kind of deploying these very, very low threshold harm reduction interventions.
All right, next question to Madeline.
Hi, Madeline Beck with the Mountain West News Bureau, reporting for NPR stations in the Intermountain West. I'm going to have a quick two-part question. The first is, do you have any information on synthetic opioids in the on reservations or among tribal communities? Second part is, I know that you have those maps with synthetic opioid overdose deaths, and like with so many other maps, there's states that aren't counted in there. And in the Mountain West, that's Montana and Idaho, it says because they have only fair overdose reporting. You know what that means? So yeah, hopefully you can answer those.
Sure. So the reservations is interesting. With looking at the individual death data, yeah, you can see that there are some reservations in the Mountain West that are hard hit. Parts of New Mexico are really hard hit. And part of that might have to do with the heroin problem as well, since there have been kind of endemic heroin use in some of the reservations. With regard to the fair reporting, this is a CDC categorization, and I should have clarified that plot. I generated those plots, and CDC doesn't like it when you present some of their data because some of these states do not report overdose deaths very accurately. So Pennsylvania is like the worst. They have a massive overdose problem, but like 60% of their overdoses are just uncategorized. They're just like, it's an overdose, it's another overdose. We don't know what it is. And it's a problem because they're not doing the testing, the toxicological testing. And so they're just reporting it as unknown other. And so CDC says, if you have a high threshold of unknown other overdoses, we categorize that as fair. And those of us who get their data, they ask us not to display it. But that if I remove that censoring, I mean, the coloration in the maps doesn't look that bad in out west. It's still not out west. It's showing parts, but not to the degree it is out east.
Okay, that's good to know. But yeah, it's hard to tell if it's increasing though, if it's not showing up on any maps.
Uh-oh, did I freeze?
Yeah.
Oh.
Bryce, you froze for a bit there. Bryce, say something. Are you back yet?
No.
You're kind of.
Is this better?
Okay, now you're back.
All right, sorry about that. Where did I cut out?
Oh, I had just made the comment that it's hard to track if it's increasing if there's no data on national maps though, even if it's not bad right now. But yeah, that's all.
Okay, next question, Kyle.
Hi, sir. Thanks for making time. I'm with Gray Television's DC Bureau. I've got a hopefully quick two-parter as well. Number one, given the financial formula you laid out surrounding why fentanyl is the obvious choice for traffickers, I'm kind of surprised to see the trends, at least in the data you presented early on in carfentanil, given its increase or its greater strength, I should say, than some of the other fentanyl. I'm curious why you think that isn't starting to take over the market. I saw some trend lines dipping down there. And then the second part is I'm curious, given I'm here in DC and cover federal policy, whether you think the STOP Act will potentially help cut down on some of the mail shipments that we've seen, supposed to have electronic pre-clearance data, et cetera. I'm sure you're familiar. So yeah, those two questions, if you don't mind.
Sure. So I'll start with the STOP Act first. Yeah, the STOP Act, the AED requirements have, those coincided with the reductions in mail seizures from China. So it could be that the STOP Act maybe has helped. That said, USPS has not hit their 100% target that they're required to do under the law. So everything from China is supposed to have AED. They never hit that. They were supposed to hit that, I think, in December 2019. They never did. I don't know what share they have now, but it is possible that the STOP Act, as well as other, Chinese authorities at port of export, mail facilities have gotten better at screening this stuff. So that could be one reason why we're not seeing the mail-based seizures coming in from China anymore. That said, we're still seeing stuff coming, new chemicals that are showing up in Europe from China. So it suggests that the production's still happening. Maybe the trafficking routes have changed or the trafficking patterns have changed. With regard to carfentanil, that's a really interesting question. Ohio is kind of case in point there. Ohio got a concentrated dose of carfentanil from middle of 2016 to the middle of 2017. Carfentanil came and left. And Ohio saw, I mean, just bodies were everywhere. It was a lot of deaths. In that year, in 2017, Ohio, the share of synthetic opioid overdose deaths in the nation that came from Ohio was about 13%. Ohio's share of the entire nation's population is less than 4%. And that disparity is largely attributed to carfentanil. And so carfentanil came and left, and we don't really know why it came and left. Some have pointed to China controlling carfentanil in 2017 is one reason, could be. Another explanation is that we think in some instances, carfentanil and some of these super potent opioids are just too potent. They're like Ebola. They just burn out too quickly. It's just too deadly. Users are just saying, forget it. Dealers are just saying, forget it, because they're killing too many people. It's real. I mean, you're talking about dosing in micrograms at that point. And so the kind of error of mistake, that margin of error is just too small for anybody who's just mixing this stuff up in, a kitchen blender and distributing it on the street. So that could be one of the reasons. That said, carfentanil is still showing up in some markets here and there.
Thank you.
Okay, so we got 4 questions. Try to get these in the next 5 or 6 minutes. We have Georgia, then Alexis, then Adriana, and then Kathy. So Georgia first.
Hi, thank you so much for your time. I'm wondering the new synthetic opioids that you mentioned what impact will those have on fentanyl? Will they replace fentanyl? Will they just be sort of like nothing burgers or what?
That's a good question. I mean, it could be in the coming years that they overtake fentanyl. We don't know yet. Some of these things, I mean, fentanyl's been around for decades and decades. And so the synthesis methods have gotten honed. People know more or less how to dose this out. With some of these other things, there's just too many questions. Some of these substances, they were designed, 50 years ago or 30 years ago with medical intentions, but never were approved because they were abuse causing. So it could just be that people haven't figured out how to use them, and the market kind of hasn't really kind of hit that equilibrium yet. It could be that people just aren't aware of it. Fentanyl is an easier drug to manufacture now, and so it could be that the Mexican drug trafficking organizations, who are really good at smuggling stuff, they're probably going to continue to hone their abilities to synthesize fentanyl as they have with methamphetamine in the last 15 years. I mean, to my knowledge, I don't think they have the kind of the background PhDs in chemistry necessary to make the new stuff. That's more happening in Asia. So it just could be that maybe it just takes time for them to figure out new synthesis and hone those synthesis methods. I think fentanyl is going to be around for a while, given that the Mexican drug trafficking organizations are just getting better at manufacturing fentanyl.
So they're not, are they, so right now are you seeing a lot of these new,
So they're not, it's hard to say with any certain degree of certainty, because again, we're not testing for them in all cases, but that said, they are showing up with greater frequency in the kind of cutting edge tests that some people are doing. So when a tox screen comes back negative for fentanyl and people are wondering why this person died, they'll send some of this out to specialty labs. Some of those specialty labs will then find, oh yeah, no, it's this new substance that we are going to call this. And they can using mass spec, they can determine what that profile looks like and what that chemical looks like. And then they're the ones who figure out, yeah, it's this new stuff that's coming on. Some of this new stuff, they come in and out, but really fentanyl is the one that's stuck around.
Thank you.
Okay, next question, Alexis.
I'm really interested in what you said about wastewater monitoring, and that's something that's been used in Europe. And I'm wondering, is that happening at all in the US? And if so, where? And if it's not, why not?
So wastewater testing has been used in Europe for many decades. In other parts of the world, Australia does it, some parts of China do it. Basically, when you take in a drug, you metabolize it and you excrete that metabolite. That goes into public wastewater systems. And then what they do is they'll sample the wastewater frequently, either at certain points in the public system or at the treatment facility. And then they'll basically, I mean, EPA does this for other things like bacteria or heavy metals or those types of things. I mean, if you tack on a screening for metabolites, you could easily do this very cheaply. And so that's what they do in Europe. They test for these metabolites, then they back out calculations based on what we know about metabolism of these drugs, and then to kind of come up with rough estimates of total consumption. I mean, this doesn't give us a full picture of what's being used or how it's being used, which are also important questions, but it gives us an early warning sense of what's showing up in these markets. It has been done in the United States from time to time, usually pilots. Universities will get some grant money to do it. Washington State did this with cannabis. And you could look at the cannabinoid loads there and THC loads there. And yeah, they showed that THC like doubled, THC consumption doubled in a period of 3 years after legalization. So it is done here and there, but it's not routinized in any way that allows us to kind of get an early warning. So Europeans have gotten to the point where now they show that, oh, Friday and Saturday nights, cocaine and ecstasy use is up. We'll go figure, because people are partying. So that's the kind of level that we would like to have, so that we could immediately warn people, oh, carfentanil metabolites are showing up in Salt Lake City. It wasn't here last week. Drug users, beware. Your stuff might be contaminated with carfentanil. Please, use with somebody else present. Use with naloxone handy. Those types of messaging campaigns can then be issued so that people can maybe then take the appropriate steps to not use with higher degree of risk.
All right, next question, Adriana.
Hi, Bryce. Nice to see you again.
Hey, everyone.
So I'm really fascinated by the East-West phenomenon, the black tar heroin on the West to the powder in the East. So the black tar heroin, I'm thinking it's because of how it's made in Mexico. But I'm wondering where the powder comes from. Like, why is it so much more prevalent in the East than the West?
So that's a really interesting question. The United States has had a long-standing heroin problem for many, many years. At one point in time, we were supplied by two sources, Colombia and Mexico. Afghanistan was in there at some point up until about the early 90s, and then that trended out. So up until about middle of 2005, 2008 or so, largely it was Mexican or Colombian sourced heroin. The Colombians had perfected the powder formula. The Mexicans were always producing black and brown tar heroin, just gummier heroin. Over time, the Mexicans have basically cut out the Colombians. They figured out how to produce their recipe, heroin number 4, I believe. And so that's when this white powder heroin they were able to capture that recipe. And so they were still supplying those markets out East, which were largely traditionally using powdered heroin. So it's still both coming from Mexico. It's just different formulas, different synthesis methods. They're both heroin. They're equally potent, and they're just different formulations, but they're both coming from Mexico now. So it's just been tradition.
All right, and final question to Kathy.
Hi, Bryce. Kathy Ritchie with KJZZ in Phoenix, Arizona. You had mentioned in one of your maps, sort of Arizona lighting up, and I was curious to know why that might be the case. Didn't look like California had the same shift in colors from 2014 to 2019.
Good question. It's not clear to me what exactly is happening. I mean, the one thing that's probably happening out West is that the counterfeit pill phenomenon is getting worse out West. I think it's one of the reasons why we're seeing increasing in overdoses out West. The trend in seizure data is increasingly suggestive of more pills showing up. These, what they call Mexican oxys. These are basically fake counterfeit pills that are produced in industrial labs in Mexico, pressed with basically industrial grade pill press machines using the same stamps and coloring agents and dyes. They're trafficking these pills over the border into these markets. It's one of the reasons why we might not be seeing it in California in that map is because California is a very big populous state, and so that large denominator is just kind of watering down that ratio. If you do look at the city of San Francisco, you do see a huge increase in the number of overdose deaths involving fentanyl, and that's probably California's predominant heroin market is San Francisco. And so it's likely that fentanyl has increased there at the same levels of Arizona, but it's just, we're not seeing it because it's just being watered down by the larger population in California. But yeah, again, pills are the future in parts of these states out West, it seems like.